Welcome, everyone. I'm Rachel Werner, the Executive Director of Penn's Leonard Davis Institute of Health Economics. I am delighted to welcome you today to LDS Conference, The Promise of Health Reform and a Public Option in the Biden Administration. Today's conversation could not come at a more opportune time. The pandemic has demonstrated the importance of having a well-functioning healthcare system. It has also demonstrated gaps in our current system, in both access and in coverage. The political moment is also opportune. Calls to repeal the Affordable Care Act have been replaced by steps to strengthen it, with proposals to reinstate the individual mandate, reform the marketplaces where individuals can buy insurance, and steps to make those insurance plans more affordable. But with the slimmest of margins in both the House and the Senate, the prospects for major health reform in the Biden administration are uncertain. Our conference today brings together some of the most creative thinkers and doers who will not only give us perspective on where we've been in health policy, but also challenge us to consider how to make our system more just for the people and communities who are often left behind. Without further ado, I'm excited to introduce our keynote conversation. Joining us today is Tom Daschle, who is the former Senate Majority Leader and one of the longest-serving Senate Democratic leaders in history. Senator Daschle has participated in the development of almost every major public policy issue in the last 3 decades, including the Affordable Care Act. Speaking with Senator Daschle today is Ezekiel Emanuel, the Vice Provost for Global Initiatives and professor here at the University of Pennsylvania. During the Obama administration, he served as Special Advisor on Health Policy to the Director of the Office of Management and Budget in the White House. Zeke and Senator Daschle, I will turn it over to you.
A distinct honor to share the stage with Senator Daschle, one of the most sagacious members of the Senate and observers of American politics, and make sense of what's going on in Washington. Senator, I want to begin with a question that really starts out at the high level, which is the Biden administration has put forward a very ambitious agenda. They passed the American Rescue Plan, $1.9 trillion to COVID. They then put up the Jobs Plan in excess of $2 trillion. And then they have followed up with the American Family Plan, another $1.8 trillion. Now, sprinkled in there is a little money for health care. In normal times, it would be a big amount of money, but in the context of $5-6 trillion being allocated, it's boosting subsidies for the exchanges and a few other things, but there's no long-term structural change. Given that agenda, do you really think there's appetite in the administration for healthcare reform and for expanding on a structural basis coverage?
Well, Zeke, first of all, let me just say what a pleasure it is to be with you again and have the opportunity to join you as we discuss the extraordinary events happening in our country and in Washington today. It's a real pleasure. Someone once said that there are decades when nothing happens and there are weeks when decades happen. I think that kind of describes what's happening right now in this country. Just an extraordinary, the magnitude of the extraordinary events taking place, both in public policy as well as in the country at large. Obviously, we're dealing with COVID and dealing with all the economic circumstances around COVID. But when you think about it, you've just described nearly $6 trillion of new public investment in fewer than 6 months in this administration. That has never happened before. There's nothing even close to that happening in the past 200 years. So this is certainly a period when decades are happening in a very condensed period of time. I do think that there is a strong desire on the part of this administration to address healthcare. I think the real question is what they think they can accomplish given the narrow margins they are working with in both the House and in the Senate. There's in the past, in our history, it's usually an election that determines legislative strategy. Well, now it's almost the reverse. The legislative strategy is going to determine the election. And Republicans are looking at that with an expectation of regaining maybe both the House and the Senate in the midterms next year. Democrats obviously want to use governance over the course of the next year to bolster and solidify their hold on the majorities in the House and Senate. And so the agenda is going to be dictated in large measure by how they can maneuver in this very narrow corridor of legislative strategy to accomplish as much of that $6 trillion in investment, in addition to meaningful changes in healthcare policy. And ultimately, I think, Zeke, what's going to drive their decision is where the votes are. Where can they get the most votes for the greatest change in public policy? You noted, I should say, that there really wasn't a real clear package of healthcare proposals in the American Families Plan or the American Jobs Plan. And so this will be ultimately something negotiated with Congress. There's a great deal of desire in Congress to address healthcare in a meaningful way. But there are big differences of opinion as to what that policy ought to look like. Far more comprehensive on one side of our caucus, far less so, more incremental on the other side. That is yet to be decided. But I'd venture to guess that over the course of the next several months, we're likely to see some clarity with regard to what that strategy is going to look like.
So can I push you just a little further on that? Because as you know, I'm a little bit of a junkie on American political history. And if you think back to the last time we had a decade telescoped into just a few months, you probably have to point to Lyndon Johnson's 1965 run right after he scored that unprecedented landslide victory over Barry Goldwater, and he got Medicare and Medicaid through. He got immigration. He got the Civil Rights, the Voting Rights Act. He got higher education. But, four major bills even exhausted Lyndon Johnson's ability to twist arms and enact things. If this administration pushes the jobs plan by July and then the American Family Plan, and we don't have consensus in the Democratic caucus, is there really any chance before we sort of in earnest get into the 2022 election, call it January or February or March, really get anything on healthcare expansion?
Well, that's a great question. And I would say that what will largely determine what gets done in part will be, and this is probably more in the weeds than we would normally want to get, but I think it's going to depend on what is the legislative vehicle that will be available to us. If some bipartisan agreement can be reached, say on infrastructure, you may not have to use the reconciliation process, which I'm sure most of our listeners and viewers know only requires 51 votes in the Senate. That legislative vehicle, reconciliation, is clearly going to be used at some point over the course of the year. It may have to be used for everything. And if it is, that's going to be a huge vehicle for the jobs plan, the families plan, healthcare, you name it. They're going to try to put it all in there and try to get 51 votes. That's possible, but it is going to be a heavy lift. Not so much in the House, but still you've got problems in the House too, given the narrow majorities. The other option you've got is, I'll go just a little bit more into the weeds and talk about Section 304. There is a parliamentary ruling now by the Senate parliamentarian that you might be able to revise a reconciliation package, which could give you a second vehicle yet this year using reconciliation. Barring that, you only have the omnibus appropriations bill at the end of the year for public policy purposes, and that also will be a big vehicle. But those vehicles are going to dictate just how much we can carry. If you think of a big truck driving through Washington, how much can we load on that truck and get all the way through town? And that, to me, is the big question. And that will be determined by where the votes are and how many votes we can get. So let me just turn the tables a little bit, and we can come back to this if you want. I'm just curious. Let's assume we had the votes, and let's assume we had consensus among Democrats on where the priorities would be. One of the things that you've done so remarkably well is given focus to the programs designed to reach the uninsured and the most vulnerable over the years. And I guess I'd be curious, how can we redesign those programs through public policy to address the clear need yet for reaching out to the uninsured and the most vulnerable in a more effective way, given our current circumstances?
So I think there are sort of progressive levels of the amount of reform that would be needed. I think at the very most basic is to think through where the uninsured are, and then to target the biggest group. So if you think through the uninsured, we have roughly 29, 30 million people who are uninsured. 10 million of them are exchange eligible but aren't in. Some of those people don't get subsidies. Most of those people do get subsidies, but still maybe don't realize how much those subsidies are worth. 7 million people are Medicaid eligible and haven't taken up Medicaid or can't do the paperwork. 2 million, 3 million, depends on your numbers, are in non-expansion states. Another 10 million are eligible for employer-sponsored insurance, but again, for a variety of reasons, often they don't think they can afford the premium outside. So if you ask me, and I look at that jigsaw puzzle, it seems to me there are two clear targets that provide the lowest hanging fruit with the most minimal adjustments. Those are the 7 million people who are eligible for Medicaid today in the states that we could get on the rolls, and the 10 million who are exchange eligible. You won't get all 10 million because some of them have to pay full freight, and it's just too much on, say, $125,000 income, even though that's a good income in America. Paying full freight on your own with no subsidies for health insurance makes it almost impossible. And those two groups, I think there are two things which are critical in my view. One is we have to go to auto enrollment. We have to make a mechanism that they can be enrolled without their effort. Penn is a big center of behavioral economics in healthcare, and it's basically going to an opt-out strategy. You're in the system unless you pull yourself out. And I think we need to figure out how to do that. There are a variety of ways to actually operationalize it. One of them is, if you're eligible for TANF, if you're eligible for SNAP, if you're eligible for any of a variety of programs, you're automatically put into Medicaid, for example, and then we sort it out when you show up for service. We also could empower lots of other organizations besides hospitals, physician offices, insurance companies where there's managed Medicaid to enroll people much more aggressively in the Medicaid program. Similarly, on the exchanges, the IRS knows income for almost all those people, and we could auto-enroll them into maybe a zero premium plan for those people, or limited premium plan, and then they would have to opt out. It seems to me both of those strategies are ones we should adopt, because if we can make those work, you could probably get north, I would think, of something like 12 to 15 million people enrolled additionally. And remember, that's 3/4 of what we got when the full-fledged ACA was enacted. And that would be, I think, a huge feather. Say you got half the uninsured that remain, huge feather in the cap of the Biden administration. And I think that is a much lower barrier than other things like, my own skepticism is, we can work on the states to expand, Texas and Florida and Georgia and North Carolina, but I'm a little skeptical that bribery, more lavish incentives are going to work. First, and second of all, whether it's really worth it politically. And third, we've seen in places like Missouri and other states, even if it gets on the ballot and the voters want it, state legislators do their damnedest to undo it and hobble that expansion. So I would go for trying to make auto enrollment, the express enrollment, where you're eligible for another social safety net program, and that you get health coverage automatically.
Well, I couldn't agree more. I think you're absolutely right. I think it's really one of the most powerful and effective tools we have, and it's an easy thing to do. That really isn't that much of a stretch over what it is we have been doing these past 10 years. So I'd love to see us make a real effort to make that a reality. And I agree with you on Medicaid expansion. We had a setback just yesterday in South Dakota on the effort to expand Medicaid, and that's in our state. And it's yet another illustration of the challenges we face. Let me just ask a follow-up a little bit on subsidies. The administration has been very vocal and very supportive of increasing the subsidies above the 400% rate. What role do you think, and what value would that hold in bringing more people in? And I've been encouraged by the enrollment this year so far. They've had open enrollment, and it's still underway. How long that enrollment lasts, I think, is a big factor. But talk to those two issues, subsidy and enrollment, and maybe I could just fold in navigators and how you think navigators can help in increasing access to and utilization of the ACA.
So I think that's a great question, and it's one of these empirical questions, which the best way is to test it and see. I do think when we look at how expensive health insurance has become, and we should recognize that going from 2010 when we passed the ACA to today, health insurance the premium has just dramatically increased, even though total healthcare costs have remained flat, because the underlying costs have increased a lot. And I do think it's a huge burden for people over 400% of the poverty line. As I said, if you're making $125,000, buying a $15,000, $17,000 health insurance package with no subsidy is a lot of burden. Not to mention if you got a really sort of employer level package, which now is clocking in at $21,000 or $22,000. And if you then say, well, for $17,000 you're going to get this high deductible plan, it becomes hard to justify. So I do think increasing the subsidy level to 500% of the poverty line or more has a lot of logic to it in terms of getting people on. But I think in terms of sheer numbers, that's not likely to move the needle as much as these other auto enrollment at the bottom end of the income bracket, which I think is very, very important and really the place that's most likely to yield the most people. Now, I think the Trump administration, understood that if you take away advertising, you shorten the enrollment period, you take away funding for navigators, you will impact enrollment. They wanted to do that, and they succeeded. We saw every year Trump was in office that the number of people without coverage or the number of people who got coverage on the ACA programs declined. I do think it's a problem, and it shows a sort of inherent problem of the fact that it's not that easy to get insurance and to wade through all of the exchange issues that you need a navigator. And I think it would be much better if we had these auto enrollment mechanisms using IRS and other information we have on people's income. I mean, we actually have a lot of information about it. And I would just note in this context, Tom, other countries which we celebrate as free market and the Republicans love to look to, places like Switzerland, you don't buy a health insurance package. They tell you a little bit, and you still haven't done it. They auto enroll you and then take the money out of your paycheck. They think health insurance is that important, and you have an obligation to do it. And by the way, for a lot of people in Switzerland, their subsidies are also quite low. And so for a lot of people in Switzerland, this is, also a financial burden, and they recognize it. But they're serious about you've got to have health insurance, and we're going to auto enroll you. There you can't opt out. Here we could have a situation where you opt out. You decide you're not going to continue, even if it's, say, a zero premium or very low premium. I think that's a better way for us to go. It would involve changes in what the IRS does and how we configure things. But my sense is, with the investment that the Biden administration wants to make in the IRS, this is probably a good thing to use the information we have more effectively to get social services to people. And I would say, Tom, one of the other things that I think is really important, we should recognize many of the things that the administration wants to do in terms of raising the minimum wage, more safety net, better access to social services, better support for children and families with children. They're likely to improve the health of people a lot. You add on health insurance and sort of take away the stress of having to pay the bill. And I think, we're probably we could have, if we can pass all of those things, we could have a real positive impact on health outcomes. And by the way, that would narrow the disparities, which I think both you and I are concerned about and have been pounding away about for years. The ACA did narrow disparities between coverage between minorities and whites, but it remains even to today because we weren't able to fully get all those people who are eligible for Medicaid or the exchanges enrolled.
That's such an important point, Zeke. I saw the New York Times article just yesterday. I'm sure people have read it, that the toxics in the air today are far more devastating for minority populations, for low-income populations, because they're concentrated in urban settings where we don't get much fresh air. And that's having a devastating consequence for mortality rates and the overall health of those who struggle. And there's an environmental justice issue here and an economic justice issue that is directly related to the health access and issues that we're talking about. I also, we talk about social determinants. One thing we haven't talked about yet that we really have to address is public health and the importance of reinvesting in public health in a more meaningful way. If COVID has taught us anything, it's how the infrastructure of public health is critical to providing better access and dealing with the social determinants that really make up sort of the best opportunity for us to keep people healthy from the beginning. Better nutrition programs for children, and that's part of the American Families Plan, is giving families and entities more of an opportunity to invest in the things that keep children and families healthier from the start. And I just hope that we can make that connection to healthcare in a more effective way, so people understand that it's all linked together. And that linkage, I think, could really create some opportunities that we haven't seen since, as you say, 1965, when Medicare and Medicaid itself was passed.
Let me ask you about the Medicaid expansion, non-expansion states. How are you reading the politics there, and how much effort do you think the administration is going to put into trying to persuade those deep red states?
Well, that's another great question. I think if you had to boil it down to one word, it would be ideology. I think the ideological opposition overrides all of the calculations that ought to be part of any public policy decision making. Unfortunately, our country is so deeply polarized, and you and I have talked about this on other occasions. That deep polarization has created a level of dysfunction that's very, very troubling, not only in Washington, but in states across the country. And the Medicaid expansion challenges, I think, are illustrative of that dysfunction. And I say dysfunction because it truly is. When you have an opportunity, like in South Dakota, to put over 40,000 people on the Medicaid rolls, and you turn away from that opportunity, not only that, but add 200, perhaps as much as $200 billion over 10 years in new economic generation, saving rural hospitals and providing opportunities for real economic growth. And you walk away from that in the name of ideological opposition. It just doesn't make sense to me. That said, I'm pretty sure it took us 17 years for the United States, for all states to embrace Medicaid. Arizona was the last state, and so it takes time. And I'm still somewhat hopeful, if maybe not optimistic, but hopeful, that over time those ideological factors are going to be addressed. How can you turn away from those resources and that reality, as complicated the challenges may be when you've got so much opportunity to address the good health of your people. So it's going to take changes, of course, in legislatures and governors and disposition and more organization. I've been encouraged by the efforts made in a lot of states like South Dakota to put it on the ballot. And, in those states where it has become a ballot issue, it's passed. And I think you're going to see more ballot issues overriding state legislatures and governors. And that's a good thing. And I'm hopeful we'll see much more of that over the course of the coming decade.
Can I ask you, so yesterday I had a call with a congressman who sits on an important committee and was talking, sort of wringing, in this case it was his hands about, no one's talking about affordability. We're barely talking about adding and expanding enrollment. How do you think the balance inside Washington between the affordability issue and the enrollment issue is going to play out? I take it that it's going to be hard to do both legislatively for reasons that we've already gone over. And do you see, given your political instincts, that enrollment is going to trump affordability in this context? I can see lots of reasons why it would. Affordability means you're going to cut, and everyone hates cutting. It does mean that, there are going to be jobs cut in a situation where the administration wants to create jobs, not cut jobs, even if they're administrative jobs at hospitals and physician offices and insurance companies. So how do you see that playing out in the Washington context?
Well, I think in the larger context, in terms of sort of bipartisan consensus, I think affordability trumps enrollment. But I think for Democrats, enrollment has always had, as you well know, a real high priority. Not really I don't think it's an either or question, frankly. I think both are important. I think there are different challenges around both. Affordability will continue to be a major problem in this country. You've heard me say this, I think, probably before, but when I was born, healthcare was 4% of GDP. When my children were born, it was 8%. When my grandchildren were born, it was 16%. And if I have great-grandchildren, it's likely to be 32 to 35% of GDP. That's not sustainable. And that's a public policy challenge that just can't be ignored indefinitely. We've, I think, suffered from lack of consensus about how to address affordability. Basically, in my view, it comes down to price. We're not overutilizing healthcare in the United States. It's price. But as you say, there are a lot of issues around price. Even negotiating drug prices is something that you would think would have pretty broad bipartisan support. It doesn't. That's a political issue. Drug prices themselves, we just haven't been able to reach consensus around how to address price, even on something as palpable and as widespread a recognized problem as drug prices, simply because I think there are ideological and political differences of opinion that have just kept us from reaching consensus. So in the meantime, I think they're going to continue to look for ways to migrate away from fee-for-service and find ways to do a better job at addressing affordability. But I'm not real optimistic. I'm more optimistic in the short term because Democrats have made it the priority around COVID that we're going to make some inroads on public health. We're going to make some inroads on further enrollment using the ACA. We'll probably make some inroads in access to telehealth and other efforts at reaching access in rural areas and other areas that, and I'm hopeful that we can address mental health as well. What I think has gotten lost in the last year, and I'd love your thoughts on this, is, opioids have been put in the back seat next to COVID. COVID has gotten all the attention, and yet it's still a major crisis that can't be ignored indefinitely. And I think we've got to resurrect through public policy efforts to address opioids as well. So those are the areas where I think we're going to see some real some movement this year, assuming we can reach consensus on what the vehicle should be in that big truck I mentioned earlier, and how much we can load it up with good and meaningful healthcare policy.
Yeah, it's interesting. I was just doing a analysis. I was asked to present about some workforce issues at another board that was looking at where to invest. And if you do look at the mental health issue, and I couldn't agree with you more. I like to joke that when I was a medical student at Harvard Medical School, I actually got the lowest passing grade in psychiatry. But I have, over the last decade, since we passed the Affordable Care Act, gotten religion on mental health and think it's way underinvested in, and that we do need to do more, if only because, it's so integral to physical health, and they're not separable in our artificial payment mechanisms, et cetera. We know that patients with chronic illness have worse mental health, and that bad mental health leads to, utilization of a lot of services for physical health that otherwise aren't helping. But if you look at our workforce, one of the key problems is there are only 26,000 psychiatrists in the country, and they're very much on the older spectrum. Psychologists, counselors, we're at 111 or something thousand, and psychiatric social workers and substance abuse social workers only 160. So you put them all together, we're somewhere between 250 and 275,000 mental health workers in the country. We're 330 million people. I mean, it's just like we're nowheresville, and we're certainly under-resourced in that area severely. And that doesn't match what I think you were mentioning before, which is, think about the children. If COVID has stressed any group in this country, it's, it obviously caused a lot of increased death among the elderly, but psychologically, it's young people who have borne a disproportionate burden of it, and women. And I think we're going to have to attend to that. And so I think mental health, and as you point out, substance abuse, once we get COVID under control, we get somewhere in the third or fourth quarter a return to near normalcy. I think this is going to be one of those issues that, again, comes right back to the surface. And to address it, it's going to be longer term because of these workforce issues. We're not going to be able to, we're going to, I think, do things to make telemental health easier and other things. But nonetheless, someone has to be at the other end of that video with a therapy session, and we need more people. And I think this is one place where it would be very valuable to invest in the workforce, because I think it's absolutely critical to have more mental health people. And we need to think of it, Tom, as an investment, not expenditures. We constantly are talking about expenditures. Some things are real expenditures, and we're not going to get a return on investment. But mental health is one of those things where it's an investment, because addressing it will have downstream effects of lowering costs in a variety of ways and dramatically improving people's quality of life. We know that if you take stressors off people's plate, their entire quality of life goes up. And, I've also noted, again, by touring around other countries, this is not an American phenomenon. Now, there are many things that are, unique pathologies to the American system, but mental health is not a unique pathology to the American system. It's everywhere, and ironically, maybe even worse in developing countries like India and many parts of Africa, where it's just totally shunned. But I do think you're absolutely right. This is one of those major public health issues that is going to come roaring back once COVID begins to recede and take a back seat.
So I've got to ask you, this is a great segue to a question I was going to ask you, even if we hadn't had this great opportunity to converse this morning. I'm pretty sure I've read every one of your books, and I read your latest book, which is "Which Country Has the Best Healthcare?" And what I was impressed by was the amount of research that you must have poured into that book. It's just outstanding. I'd recommend to all of our viewers and listeners to get a copy. But I would just ask, in this context, Zeke, what were your takeaways after all of that research and writing the book? What is there anything we could learn from the international experience around some of these issues, around affordability, around dealing with the enrollment questions and the vulnerable and the uninsured that other countries face? Clearly, they've all had to address these challenges too. And if you had to describe one or two takeaways from your research, what would they be?
Thanks for the plug. I really appreciate it. But I would also say it's a great way to visit a lot of countries and to meet some very unique people. Actually, right before this, I was talking to one of my German informants about the German response to COVID and learning a lot from them. So I would say on the mental health issue, probably the Netherlands has got a really good system where they empower the primary care doctors there to have a nurse who specializes in mental health issues in the physician offices to be the first line to deal with anxiety and depression. Now, they don't deal with the very complicated major depressive disorders or bipolar disorders, but for many people, they are adequate to provide therapy. And over 80% of the primary care doctors have someone literally in their offices. And I think that's something we really should very strongly move to. There's a lot of good data on that. I would say the other really important, one of the other two or three important lessons that I've taken away is we have huge administrative bloat, various estimates that 8% of all the spending is administrative costs. That's not on the public side so much, although there is some there, but it's really on the private side. There's a lot of things that even places like the Netherlands and Germany or Switzerland that have multi-payer systems, they're not, the government is paying everyone. The government does collect the money, but gives it to insurance companies or sickness funds in those countries. They standardize lots of the private sector that has a big impact on reducing the administrative costs. So there's only a few standard health packages. There's standardized deductibles and co-pays. There's standardized billing. So you don't get these wild price differences. You don't get a lot of administration around each employer having their own particular package, and then thousands of different plans basically that a doc has to and a hospital has to keep record of, and increasing the filing. They all have some central clearinghouse for the claims. I think that is something we really could do. Congress would need to enact it to really, we've seen that employers are not themselves going to standardize their benefit package and get rid of their benefit consultants who keep telling them, you make this change and makes no difference, but the benefit consultant makes a lot of money. That standardization, I think, could save a lot on administrative costs. Congress wouldn't have to pay a lot for it. I mean, it probably would have to set up a central claims clearinghouse. It's the kind of wonky thing. The government wouldn't make a lot of money, but it would level the playing field and actually make it much more efficient. And I do think that's something that looking at, again, even other countries with lots of different insurers makes a big difference. The second thing I would say that really works in other countries, and this isn't original to me, but, every other country has a package, except Switzerland, really, like us. Every other country, Germany is like the government collects the money, but gives it out to the insurance company. But this is the total pot. You want to spend more, you're going to have to pay out of your pocket. And if doctors increase their utilization, the amount we give them, 90 cents on the dollar, 92 cents on the dollar. You see this in Germany, you see this in Switzerland, you see this in Taiwan. And it does seem to me having some budget is really good, overall budget for the country, really good discipline. And in the United States, states like Massachusetts and others that have tried this, and we're seeing an increasing number of states, Oregon, even my own Pennsylvania, we are, having a budget, not letting it increase more than the growth in the GDP, I think is a kind of discipline we all have in our own houses because, what comes in can go out, but you can't go out more than what comes in. I think that's very important for healthcare, and we have not done that. And I think it's really would be important discipline. I've said this before, and we're going to have to wrap up soon, but, if we could keep healthcare spending at 18% of GDP, we'd all be happy, right? I mean, we would view that as a huge victory. And I think that's where we should target ourselves. So with that long-winded answer, I'm going to turn it back to you, Tom, and you get the final word here. final thoughts on what we're going to do about coverage and enrollment.
Well, Zeke, first of all, let me just say I couldn't agree more with your comments. And I just go back to something you asserted earlier, and that is we have to look at a lot of this as investment, not spending. And the more we can put it in the context of meaningful investment, I think the more conducive we're going to be in reaching some of our aspirations in health in the coming years. I guess I would just say as we wrap up that this is a transformational time. There's no question about it, both in the private sector side as well as in the public sector side. In the public sector side, at the federal level, there are really three different entities that are going to have a huge impact on the future of health policy. We haven't talked about the Supreme Court, but we're going to get a ruling somewhere this year on that. I'm somewhat optimistic, but you never know. But the Supreme Court can't be discounted as a major force in what public policy around healthcare is going to look like. The second, of course, is the administration and the enormous regulatory authority and opportunity they have. I don't know how many times it's been amended now with the ACA, but there used to be over 1,400 mays and shalls in the Affordable Care Act. And that means that the administration, any administration, has wide latitude to address the many, many opportunities it has to influence public policy through good regulation and direct involvement by the agencies involved in government. So that too is going to have an enormous impact on public policy. And then third, what we can do legislatively. And we've got the majorities in the House and Senate, I should say we, the Democrats, and I'm just hopeful that we maximize whatever vehicles we finally decide are most helpful to us as we make the most difference in health policy statutorily. We will do that. We just don't know what it's going to look like. And to our audience, Zeke, I just say this. Don't consider this a spectator experience. Please get engaged. If you're part of an organization, weigh in. If you're an individual and don't know the member of Congress that represents you, get to know that person, because it's never been more critical for you to be a part of the voice in America, to give Congress direction, to give Congress the kind of guidance from your perspective. You're all, as viewers today, obviously interested and deeply committed to healthcare. So use that commitment in a meaningful way to connect with Congress and do all that we can to make this democratic republic more functional and more responsive to the needs of our people. With that, Zeke, I'll turn it back to you and we'll go from there.
Tom, this has been incredibly wonderful conversation. As usual, I think you've taken us down into the inner workings of Congress and vehicles that we need and reconciliation options, but also up into what is possible and to think creatively and also to now give us a call to arms. Let me just conclude with one thought that your comments raised for me that I like to put through that I've also learned from other countries. Simplification is a really important thing. One of the problems of the American healthcare system is it's by far, by an order of magnitude, if you wanted to measure it, more complicated than any other healthcare system in the world. And I think simplifying enrollment into insurance, simplifying the options offered in private insurance, simplification would make a big deal, right? I mean, we have a complicated drug pricing system, PBMs, kickbacks, discounts. It's too complicated for most people to understand, even experts. So as we go forward, I think one of the things that can help in enrollment and affordability in almost every aspect of healthcare is a little simplification. And so as you think of your favorite intervention and change and modification and reform, let's think about how it could simplify the system and make it easier, because I think that will save. With that, I think we've hit the mark exactly, Tom. Continue to enjoy the weekend and continue your strong advocacy and help. Now over to you, Rick.
Thank you both very much. I appreciate you both joining us today. It was a wonderful conversation, and it was great for all of us in the audience to feel like we were part of that private conversation you all were having about these pressing issues in healthcare. So thanks so much for joining us.